BMT سيتنج، والدكتورة نيرة هي اللي عاملة السيشن، إنما لها 15 دقيقة لغاية لما الكمبيوتر بتاعي يتصلح.
Thank you very much, Professor Dr. Mohsen Alfi, for your kind introduction. My talk today is about the life-threatening bleeding in hematopoietic stem cell transplantation. This is my disclosure, and this is my agenda. 1/3 of the allogeneic transplanter transplant patients suffer from at least one bleeding episodes. Usually it is in the gastrointestinal tract or the genitourinary tract. The risk factor for life-threatening bleeding is acute GVHD, severe thrombocytopenia, and transplant-associated microangiopathy. The death from bleeding is rare. It's less than 10%, except in case of diffuse alveolar hemorrhage as well as intracranial hemorrhage. The intracranial hemorrhage can occur within 2 months post-transplant, and death can occur within 1 week of the diagnosis. Now, I will start my talk with the thrombocytopenia in hematopoietic stem cell transplantation. This is a very nice graph that shows thrombocytopenia during the different phases of transplant. As we all know that during the pre-engraftment period, thrombocytopenia is almost universal. And the Blood and the Bone Marrow Research Center has defined platelet engraftment as having 20,000 platelets with no platelet transfusion in the previous 7 days. And this happens usually by day plus 20 post-transplant in matched related donors. So by plus 100 post-transplant, the platelet count reaches up to 100,000. And this is very important, or even above. And this is very important because if the platelet count does not reach by this time 100 or above, this is an ominous sign, and this represents a very important factor of reduced overall survival. So what are the aberrant platelet engraftment? We have the first is prolonged isolated thrombocytopenia, which is defined as having a persistent platelet count of less than 20 at day 60 post-transplant, but with the engraftment of all other lines. And we have the secondary failure of platelet recovery, and this is a definition that was proposed by the Seattle group, which represent the decline in the platelet count and the need for platelet transfusion for 7 days and after the platelet engraftment. And we have also the poor graft function, and this means the presence of cytopenia together with hypoplasia or aplasia of the bone marrow, but we have a complete chimerism, donor chimerism, and there is no signs of relapse. The prolonged isolated thrombocytopenia occurs in 5 to 20% of the cases, and it is usually because of the lack of megakaryocyte differentiation or the peripheral destruction of platelets. The secondary failure of platelet recovery occurs usually because of the low stem cell dose. Some of the drugs that are used during transplant, like ATG and alemtuzumab, and the conditioning regimen, particularly the TBI and myeloablative and high-dose chemotherapy, and finally the CMV infection and the drug used for CMV infection, which is again cyclovir. The poor graft function is usually because of the low stem cell dose also, but also the impaired liver function and the kidney function of the patient also predispose for poor graft function, and also the GVHD and viral reactivation. The thrombocytopenia in hematopoietic stem cell transplantation, usually we don't have a serious bleed if the platelet count is 10,000 or above. But also there is no fatal bleed if the platelet count is 5,000 and above. This is why some center defer platelet transfusion if the platelet count is above 5,000 in order to avoid side effects of the platelet transfusion as well as the risk of alloimmunization. But in actively bleeding patient, we have to keep the platelet count above 50, and particularly also if you are using drugs like ATG and alemtuzumab with a known mechanism to reduce platelet counts. The mortality rate is significantly high for patients with post-transplant thrombocytopenia, and it is correlated with the number of bleeds as well as the bleeding site. Sometimes we use CD34 selected stem cell boost in order to improve the platelet, the thrombocytopenias that occur as a result of poor graft function. But now there are reports that have described the measurable response of thrombopoietin receptor agonist in the treatment of platelet related to post-transplant thrombocytopenia. This is a very nice table that shows the L-thrombobag experience in the post-transplant period. As we all see that the studies have investigated the response of L-thrombobag in prolonged thrombocytopenia as well as the secondary platelet recovery. And they have showed an increase in the response, which ranged between 50% and 100%. And this is because we all know that L-thrombobag, not only it improved the differentiation of CD34 into megakaryocytes, but also it affects the other cell lines. In the same paper, they published the table with the romiplostim, but there is paucity of data about the romiplostim effect on the different hematopoietic stem cell line. And usually the studies have used the romiplostim for secondary platelet failure of platelet recovery, and they showed the same response. Now, when I speak about the life-threatening bleeding during transplant, I would like to imagine an iceberg with the thrombocytopenia and coagulation disorder being the tip of the iceberg. But if you did not address what lies beneath the surface of the water, you are going to lose your patient. And this is what is the endothelial cell dysfunction. During transplant, and because of the conditioning and because of the release of cytokines, as well as the release of bacterial endotoxin, which are translocated from the gastrointestinal tract, the complexity of the engraftment, as well as the alloreactive T lymphocytes, there is endothelial damage. And the endothelial damage will cause the endothelial activation, and if the stimulus is strong and persistent, this will lead to a constellation of disorders that we call the vascular endothelial syndrome, which includes the VOD, the diffuse alveolar hemorrhage, the transplant-associated thrombotic microangiopathy, and the graft versus host disease. I will start with the transplant-associated microangiopathy, and this is a syndrome with a feature of TTP and hemolytic uremic syndrome. The incidence is 8.2%, but the mortality rate reaches up to 75% within 3 months after the diagnosis. It's mainly because of the endothelial damage that will cause release of pro-inflammatory cytokines and the activation of the complement cascade. This is the proposed diagnostic criteria for the transplant-associated microangiopathy, and these criteria are proposed by many working groups for TMA, and they all agreed that schistocytes should be a very important diagnostic criteria, the de novo thrombocytopenia, as well as the increase in the LDH, but according to the different group, there are different other symptoms and signs, including kidney and neurological manifestation, hypertension, and even the increase in the soluble serum complement 5B or complement 9 is not in all the working groups. So if I'm talking about the life-threatening bleeding, I will talk about the intestinal TMA. And the intestinal TMA the patient will present with abdominal pain, vomiting, ascites, and gastrointestinal bleeds, which mimic the gut GVHD as well as infective colitis. The diagnosis is mainly through a biopsy to examine the submucosal vasculature. And it's very important to know that the intestinal TMA occurs following the renal TMA, and the concurrent occurrence of TMA as well as the renal TMA occurs only in 13% of the cases. So it's very important also to know that the patient with intestinal TMA have a greater risk to develop GVHD on top, acute gut GVHD, more than those who have only renal TMA. And finally, you have to have a high degree of suspicion in order to diagnose intestinal TMA, because it mimics the GVHD, and it could be a part of systemic TMA or a part or an isolated entity. So what to do if you have intestinal TMA? The first thing is to withdraw the calcineurin inhibitor or the mTOR inhibitor that you are using as a graft versus host disease prophylaxis, and because they are involved in the development of TMA. But to protect your patient, you have to have another prophylaxis, which is usually the anti-interleukin 2 receptor antagonist, which is now available is the basiliximab. Some centers use the defibrotide, which is a drug used for the treatment of VOD, but because it has a protective effect on the endothelium. According to the American Society of Apheresis guidelines, they do not recommend the use of therapeutic plasma exchange for patients with TMA because of decreased efficacy. However, there are some patient case-controlled reports that reported that we can use the rituximab with the plasma exchange. The main line of treatment is a complement-directed therapy, which is the eculizumab, which is the anti-complement 5, since it is increased in transplant-associated microangiopathy with a very good response rate ranging between 50 to 93%. Now, I will talk about a very serious disorder with an ominous prognosis, which is the diffuse alveolar hemorrhage. The incidence ranges between 3 to 8%, with a mortality rate reaching up to 100% and occurs within 30 days of transplantation. The patient presents with acute hypoxemia, hemoptysis, and dyspnea. The chest radiology shows either new or aggravated diffuse pulmonary infiltrate. The diagnosis is mainly through bronchoscope with a progressive bloody bronchoalveolar lavage or an increase in the percentage of hemosiderin-laden macrophages. So in diffuse alveolar hemorrhage, we have the chemotherapy that we are giving. We have the drugs that we are using like for treatment for prevention of graft versus host disease that will cause alveolar epithelial injury, and then it will cause inflammation and capillary endothelial injury with cytokine storm. There are some risk factors which include the transplant of non-malignant disorder rather than malignant disorder. It is more common in autologous more than allogeneic transplant, and it is more common in the umbilical cord transplant rather than the bone marrow or peripheral blood transplant, and this is because of the poor immune reconstitution. Also, other risk factor includes neutrophil engraftment, which is early neutrophil engraftment that will cause endothelial damage, and the delayed thrombocytopenia. What to do in diffuse alveolar hemorrhage? One would think that the first line of treatment would be the transfusion. However, every transplanter knows that hematopoietic stem cell per se is a risk factor for TRALI, and especially in the period of inflammation like diffuse alveolar hemorrhage. So we have to defer platelet transfusion as much as we can in these patients. The cornerstone treatment for these patients are glucocorticoids. The dose of the glucocorticoids is still debatable. Some say that the high dose, which reaches up to 30 milligram per kg in methylprednisolone, is effective in improving the overall survival and reducing the need for invasive mechanical ventilation. Some centers are using the aminocaproic acid systemically and the tranexamic acid through nebulization, and, but still the clinical importance of such drugs are to be investigated. Some centers use recombinant factor 7 for in order to bypass the intrinsic pathway, and this is based on a trial that was published in 2005. They investigated the use of different doses of recombinant activated factor 7 in patients with bleeding post-transplant, and they included diffuse alveolar hemorrhage in those patients. They used a dose of 40 and 80 and 160, and in their analysis they showed that a dose of 80 mic per kg every 6 hours in the first 36 hours had a better outcome with a better, with improvement in the bleeding score. They went further, the studies, and the most recent studies now are using the recombinant factor 7, which are directly delivered to the lungs through the bronchoscope, or even by nebulization, in order to reduce the side effects of recombinant factor 7, and they are used usually in combination with glucocorticoids in refractory cases. Now, I will speak about the nightmare of every transplanter, which is the GVHD. Not only because of the symptoms and signs that are wide and variable and very hard to control, but also because it distorts the nice picture that we are drawing to our patient that he is going to be cured with no pain and suffering. I will start by this case, which I saw during my fellowship in UK. This is a 12-year-old girl who had a haplotransplant from her half sib for sickle cell disease. She had a conditioning which included the fludarabine, Cyotepa, Cytoxan, ATG, and TBI with the low dose. At day plus 16, she had a neutrophil engraftment. She had several episodes of neutropenic fever and non-neutropenic fever. At day plus 28, she had a chimerism, which is full donor chimerism. But at day plus 48, she developed anorexia, vomiting, loss of weight, and severe diarrhea, watery diarrhea. She was diagnosed as skin rash, and she was diagnosed to have skin GVHD as well as gut GVHD. She started mesilpred, but after 5 days, she started to develop hematemesis and bleeding per rectum, and she was started on budesonide orally with TPN. She was considered steroid refractory according to the definition, so she started ECP, which is used for the skin rash, and she started also monoclonal antibody for the gut GVHD, as well as octreotide in order to to stop the life-threatening bleeding. She had a complete resolution of her skin and gut GVHD, but after 50 days of steroids, which predisposed her to other viral reactivation. So she had several CMV and ABV reactivation following these episodes. So the gut GVHD or the acute GVHD, the incidence is 40 to 80%, which is a very high incidence. The gastrointestinal tract show a cumulative incidence of 60%. As we all know, the main pathophysiology is the upregulated effector T cells of the recipient, as well as the abnormally activated antigen-presenting cells, which act with the donor alloreactive T cells to produce cytokines, which include interleukin-2 and gamma interferon, that will attack the different target tissue, causing the different symptomatology. It was believed that also the imbalance in the gut microbiota is involved in the acute gut GVHD. So this is why recent studies have used the fecal microbiota for the treatment of acute GVHD. The patient presents with diarrhea, which is secretory and watery up to liters per day. And if it is stage 4 gut GVHD, the patient will present with blood in stool, hematemesis, and even melena. And the cumulative incidence of gastrointestinal bleeding of any severity is 9%, and it reaches 2% if it is severe bleeding. Also, it is now known that in gut GVHD, we have a reduced factor 13, and this is because of the consumption of factor 13 in the inflamed intestinal wall. The factor 13 is not only important for the coagulation cascade, but also it is important for the healing of the intestinal wall. The diagnosis of gut GVHD is through an endoscopy, either upper or lower endoscopy or a rectal biopsy, but make sure that you do a virology screen of the tissue in order to exclude infective colitis. What to do in case of gut GVHD with bleeding? You have to correct the thrombocytopenia, you have to correct the coagulopathy, and you do give acid suppression drugs. Continuous infusion of octreotide, knowing its role as a vasoconstrictor to reduce the bleeding. Sometimes we use the budesonide in order to treat the gastrointestinal, to act locally on the inflamed gut. But you have to to be cautious if you have CMV colitis associated with GVHD. But again, the glucocorticoids is the cornerstone. If the patient did not respond to the glucocorticoids, you have many drugs that are, the mechanism of action of these drugs are mainly through T-cell depletion, which is the main cause of GVHD, and this includes anti-interleukin-2 basiliximab, which is used in this patient, infliximab, as well as also you have to optimize your immunosuppressant therapy. This trial which is called the REACH-2 study, it was published in 2020 in New England Journal, and they used ruxolitinib, which is a JAK inhibitor, in the treatment of acute GVHD, whatever the symptomatology or sign, I mean skin, gut, as well as liver GVHD. And they showed a very good response at day 28, not only a good response, but a durable one at day 56. And at last, I will speak about the hemorrhagic cystitis. This is another case that I saw, which is a 10-year-old boy who had a matched sibling transplant for Fanconi anemia. He had a conditioning done with the fludarabine, cytoxan, and alemtuzumab. At day plus 28, he had 94 chimerism donor. He had the CMV reactivation at day plus 25. And received the first line of treatment, and he did not improve, so he had to have combination of antiviral. At day plus 36, he developed BK hemorrhagic cystitis, and which was persistent, so he had to have intravesical cidofovir, which are, and he received 2 doses with a complete resolution of hemorrhagic cystitis. It occurs in 20% of the cases, but the BK cystitis occur in 8 to 25% of the cases. There are several risk factors, including the allogeneic transplant, the GVHD, CMV positivity, and this has happened with our patient, the myeloablative conditioning. It occurs more in haplotransplant and cord blood transplant because of the poor immune reconstitution, as well as the use of post-Cy in haplotransplant. The patient presents with dysuria, pain, and increased frequency, and hematuria. Either early onset, and this occurs within 24 hours, 72 hours post-transplant because of the drug, which is cyclophosphamide, or late onset that occur because of the viral infection. The main treatment is a supportive therapy. You have to try to taper the immunosuppressant because mostly the hemorrhagic cystitis, especially the late one, is related to viral infection, to give the appropriate antiviral and the appropriate antimicrobial. Some argue the efficacy of corticosteroid in the treatment of the late onset, which are persistent, because now they are assuming that it has an immunological background since it occurs in the settings of graft versus host disease. New technology, now we can transfer a virus-specific cytotoxic T lymphocytes, and this was planned for our patient there in UK. If the patient did not respond to the intravesical cidofovir. And this is a very nice technology that we use a virus-specific cytotoxic T lymphocyte from the original donor or from an individual who is seropositive in order to attack the virus and clear the virus. Some invasive procedure other than intravesicular cidofovir, like a diversion or cystectomy, could be used in patients with severe forms. My take-home message: in the BMT setting, an optimal management of life-threatening bleeding necessitates addressing the inflammatory aspect rather than only correcting the coagulation defect. Thank you, and I would like to thank all the unit, the Pediatric Hematology Oncology BMT unit, for their continuous amazing job. Thank you.